topic is concerns regarding the IOL power calculations in penetrating keratoplasty, also other corneal transplants. Most of the work which I shall be presenting in this presentation was done in LV Prasad Institute, where I was working till about a year and a half back. So this is a case of a 63-year-old gentleman who was being treated by us for HSV keratouveitis. When he came to us at this particular visit, his keratitis and uveitis was stable, and he had a scarring and a cataract, which was responsible for his diminution of his vision. So the plan was to do a triple procedure. We took a keratometry, a standard K of 44 diopters, and based on that, the IOL power calculation was 21.5, which was used for this particular patient. So a routine standard PK triple was done. Post-operatively, the patient did well with the vision of 20 by 125 improving to 20 by 80 on pinhole. However, 6 months later, the vision dropped to 20 by 320 and with pinhole 20 by 125. And what was the refraction at 6 months later? As you can see, -10 spherical and -12 cylinder at 170 degree. And what was the reason for that? So this is in the topography. As you can see, the keratometry in the operated eye now is 48.8 and 55.3. What we assumed during the IOL power calculation to be 44. But now in 6 months, this has changed to a very steep cornea. And this is the reason why the patient had so much of a refractive error. So now people are thinking, including myself, that probably triple procedure may not be the procedure of choice in these situations, and people are now thinking about doing preferably a sequential surgery. Earlier, there used to be a major concern about the damage to the endothelium, which one may have after doing a phacoemulsification in an operated penetrating keratoplasty cases. However, now there's much better, safer techniques of phacoemulsification, and the viscoelastics are also much better, and there is hardly any damage to the endothelium if it's a normal average cataract. And the IOL power calculation would be much better if you do a sequential surgery. Talking about the triple procedure, it was first described by Taylor way back in 1976. The advantages are obvious in the sense that you do one surgery and there is a faster visual recovery. However, there are intraoperative concerns, like because you're doing a surgery in an open sky environment, so the risk is much more. Many a times you will have a very significant upthrust, and it's not easy to do a ECC in this situation. Personally speaking, over the past 20 years of my corneal surgery experience, I have had 2 expulsive hemorrhages in PK. The main problem, however, is post-operative visual gain, that is the refractive error. So there are various studies which have shown that the refractive error which one ends up after a triple procedure is very unpredictable, and it can range from as low as -15 diopters to +8 diopters. And the patient therefore has a very significant vision problems. And therefore, this amounts to difficulty in calculating the IOL power for the triple surgery. And the main problem is basically as to what K should you choose for this. Many situations you may have a proper keratometry reading available in the other eye or the fellow eye, which you can use for calculating the IOL power calculation. However, if there is no significant or a regular eye in the fellow eye, then you may end up using a standard K, which we routinely take as 44 diopters. Many people have also used 42, 43 diopters as standard K, but the problem remains the same, that the post-op refractive error calculation is very unpredictable. There is at least one study where the author, Dr. Slaudin, has used donor keratometry. That is, he has used the keratometry which he did in the donor eyes before they were retrieved from the diseased person, and those K readings were used for calculation, and he In his paper, he has mentioned that they were significantly better than the standard case. However, more and more people, including myself, now I want to go for mainly the sequential surgeries as long as possible. Now, sequential surgeries you can do in two modalities. One is, suppose it's a patient has a hard cataract where you cannot possibly wait for a cataract surgery later on. So in these situations, I prefer to do a cataract surgery, open sky cataract surgery or a ECC. However, I do not implant the IOL in these situations and just do a peak. After 6 months or so, when the keratometry stabilizes, then you can put in a secondary IOL. So this gives you, in this particular study, about 95% of the patient had plus minus 2 diopters, which is much better than the standard K values. And now, as I said, with the advanced and the safer techniques of phacoemulsification and better viscoelastics, you can always do a PK first, and maybe after about 6 months, you can plan a regular phacoemulsification process. What you need to understand is a lot will depend whether it's what kind of a cataract is it, and whether it's, if the patient is one-eyed and that is this only seeing eyes, then probably triple procedure is the only option, because you cannot possibly wait for 6 months for the keratometry to stabilize and then do a secondary setting. So these are the situations where you will still end up in a triple procedure. However, if the cataract is not very advanced, I prefer to do a phacoemulsification 6 months after the PK. And where the cataract is very advanced, I prefer to remove the cataract and leave the patient aphakic and implant the IOL after a proper biometer after 6 months. So the combined approach would be that you do a lens removal but do not put a IOL. So this example will clarify, like this patient had a triple procedure done with PK, ECC plus IOL, and the standard K of 44 were used. And you can see how the refractive error is minus 2.75 sphere and minus 6 cylinder, roughly a spherical equivalent of about minus 6. In this particular case, where the patient had a corneal amyloidosis, I chose to do a sequential surgery. That is, I just simply did a PK. And after 6 months, we did a phaco with IOL. And you can see the refractive error is much more predictable, plus 1.25 sphere and minus 0.75 cylinder, a spherical equivalent of just about plus 0.75 and a 20 by 20 vision thereafter. So I believe a sequential surgery is a much better option wherever it is possible. That should be preferred. The other scenario would be these days is a DSEC with phaco and IOL. So in this situation, what you need to understand is that these patients tend to, the keratometry is not an issue here, but these eyes, because you are adding thickness to the cornea, these eyes tend to be hyperopic after the surgery or after the DSEC. So you have to allocate for that hyperopia. So you aim in your regular biometry, you aim for minus 1.5 diopters in DSEC triple procedures. In DMEC, the hyperopic shift is about 0.25 to 0.5 diopters. So here you basically aim for a minus 0.5 diopter. Otherwise, the biometry is the regular biometry that you do for DSEC and DMEC. So that is all about the biometry concerns in PK or corneal transplants. And thank you for your patient listening.